All right, thank you, everyone. Good to see you. So today, I'm going to be giving you a little overview of non-intensive therapy of older and unfit patients with acute myeloid leukemia. Now, these are not always the same. There are some people who are older who may be fit, and there are some people who are younger who may be unfit. So two separate populations, but how to treat these patients with different therapies. Now, I'm not going to go through the massive revolution that we've had already in the treatment of low-intensity therapy, which is the addition of venetoclax to lower-intensity agents. My purpose today is to try to show you what we can do more, how we can build on the success that we've had already with some of the things that we're doing. I think some of that Dr. Kuntaj already mentioned and Dr. Ravandi mentioned as well, to see how we can build on our current successes. Number two, I'd like to show you that maybe we don't need intensive chemotherapy. Maybe we don't need 7 and 3 in patients who are 60 and older. There are always patients who we see in the clinic who may be 60 and we call them fit, but we're not always comfortable giving them intensive chemotherapy. Nonetheless, we do because we don't have options. But if we did have options, potentially we can use things that are just as effective but much more tolerable. And number three, I think we need to recognize and understand the importance of sort of long-term therapy in many of these patients, and to recognize and have the families and patients recognize that this is a long-term commitment when we're treating acute myeloid leukemia. It's not just induction consolidation, but potentially a much longer-term therapy requiring ongoing surveillance of things like minimal residual disease at the start of therapy, at the time of response, detection of subclones that arise, and addressing each of these clones as we go on with maintenance therapy, with MRD eradication. So a long-term total therapy to really achieve the long-term survival and cure that we do in these patients. And so for years, we've had this debate, should we use low-intensity therapy versus high-intensity therapy in older patients with newly diagnosed AML? In our younger patients, 20 and 30 years old, sure, we use very intensive chemotherapy. We get them into deep response, try to get them to allogeneic stem cell transplant. In the older patients, we come to this conundrum. They have many comorbidities. They may be more frail. They may not be able to tolerate the intensive chemotherapy, particularly the high-dose cytarabine and the anthracycline-based therapy. And so we say, how do we determine who is fit, who is unfit? Because if we use lower-intensity therapy, well, the survival is modest, the remission rate is low, the risk of early death is low, which is good. But what if I told you that now, with the introduction of many of the novel therapies that you already heard about and that you will hear about over the next day or so, is that we've actually been able to improve the efficacy, to improve the response rates while still preserving the efficacy that we previously saw with intensified chemotherapy. So in the past, where we went from standard dose cytarabine to high dose cytarabine to improve response rates, we went from DANO 45 to DANO 90 to improve response rates and overall survival. Maybe we don't need to intensify, but instead substitute with targeted agents in specific subgroups. And so I think we're finally entering the era where we are starting to realize the promise of biologically targeted therapy in acute myeloid leukemia. We had a beautiful talk earlier this morning about targeted therapy in CML. I think we're starting to realize, and in AML, I think we're just at the tip of the iceberg, just scratching the surface of where we can go with some of these therapies. And I think the first thing is that we need to identify and recognize that AML is heterogeneous, that there are distinct subgroups, and each subgroup may be sensitive, may be very sensitive to a specific therapy. So first, identify the subgroups, split them apart, and then treat each subgroup with the most optimal therapy possible with the newer therapies that we have available now and that are in the pipeline. And menin inhibitors being a primary example for those who are MLL rearranged or potentially NPM1 mutated. Then we leverage these targeted therapy to increase the efficacy without intensifying the chemotherapy and still preserving the safety and low early mortality in an at-risk population, specifically those who are older and or unfit. And finally, this concept of post-remission therapy. So one of the same problems that we have in these patients who are older and frail is that those same patients who cannot tolerate 7 and 3 or Clea, venetoclax, or FLAG-IDA, well, those are the same patients who are also not eligible for allogeneic stem cell transplant. So while you may achieve high rates of remission, the relapse rate is still there, 50 to 60%. How do we develop better and smarter maintenance strategies and surveillance of these patients with things like next-gen sequencing that's available real-time for clinical use, validated flow cytometry monitoring, validated NGS monitoring, and then smart maintenance therapies over the long term to maintain those remissions and cure. And so this is some of the things that I'd like to show you today. So we know, as I mentioned very briefly, there's been an evolution in the treatment of older patients with acute myeloid leukemia. So there have been modest outcomes with HMA alone, with CR rates in the range of 18 to 20% and median survival in the range of 8 to 10 months. With the addition of venetoclax to HMAs, we have now dramatically improved response rates to 37% CR rate and 66% CR/CRI rate, with a median survival of 14 to 15 months. So really, really nice improvement with the addition of HMA to venetoclax. Similarly, with low-dose cytarabine and venetoclax, we have made a jump from what you would see with low-dose cytarabine alone. This is the VIALE-A study showing an improvement in response rates and an improvement in overall survival. So then the question becomes, how do you further improve on these therapies? So this is where we're at now. Our job is to push the field, to move it to the next generation where we can even further improve outcomes of these patients. So there's at least two ways that we can further improve, right? So we have a really nice backbone, HMA venetoclax, which has X response rate. How do we improve that? There's been a strategy of HMA ven as the backbone plus another therapy, the so-called triplet approach, right? So HMA ven plus a FLT3 inhibitor. You've heard a little bit from Dr. Ravandi. You'll hear more from my colleagues later this morning. People are using HMA ven plus monoclonal antibodies. There are studies looking at aza venetoclax plus gemtuzumab ozogamicin, plus a drug called IMGN, which is the antibody drug conjugate. There is HMA ven plus immune therapy, sabatolimab, TIM3 inhibitor, CD47, magrolimab in subsets of patients with high-risk disease, as well as bispecific antibodies. So here the concept is, we have a good backbone HMA ven, it's low intensity. How do we add something to that to further improve the response rate in specific subgroups? And so this HMA ven plus investigational therapy has been an important approach, and I'll show you some caveats of that in the next couple of slides. The other approach, so one is to use HMA ven plus X. The other approach is, well, we know that venetoclax adds and improves the response rates to low-dose cytarabine, to hypomethylene agents. What if we change the backbone to something a little bit different? And you heard about the cladribine low-dose cytarabine backbone, which we have been using for a decade in patients who are older with acute myeloid leukemia. What if we add a new backbone with some of these therapies? Can we further improve outcomes? And I'll show you some examples of that. So first, you'll hear about this the AGILE study. We know that AZA plus ivosidenib significantly improves overall survival and response rates in newly diagnosed patients with IDH1 mutated acute myeloid leukemia. And I think Dr. Turchione will be presenting this as an oral presentation in just a moment. But here's an example of the triplet therapy. And I think when we get to the triplet therapies, I think you really have to be smart and clever about how you design these things. Because as we get into this concept of triplets, maybe quadruplets, similar to the myeloma folks, we not only have to look at the toxicity of each of these individual drugs and adjust the doses of the drugs going forward, maybe give them at different times so as not to cause drug-drug interactions, but I think that this drug-drug interaction is an important concept which we need to become more aware of. We need to look at more drug levels, how these affect CYP3A, and how we can avoid these drug-drug interactions. So this trial designed by Courtney Denardo and our group is very clever because it recognizes that venetoclax is an inhibitor of CYP3A4, while ivosidenib is actually an inducer of CYP3A4. And so what they did is they actually staggered the start of these two therapies to avoid that drug-drug interaction, to avoid toxicity, to avoid abnormal drug levels, to potentially reduce efficacy. And you can see here the outcomes of this triplet combination with HMA, ven, ivosidenib in the newly diagnosed patient population, CR/CR rate of 92% in newly diagnosed patients who are older, very low intensity therapy, very well tolerated, MRD negativity rate of 60% in this count. So an example of a triplet therapy where you really need to take care and understand the drug-drug interactions, the toxicities, and adjust the doses accordingly. You heard another example from Dr. Ravandi where we stopped the venetoclax at day 14 if there are no blasts in the bone marrow. So these are the strategies that is going to have to become part of our armamentarium on a regular basis. So about 10 years ago, under the leadership of Dr. Kintarji in our institution, we became frustrated with the use of HMAs as a single agent in newly diagnosed older patients with AML. And so we developed a double nucleoside backbone with cladribine and low-dose cytarabine, but also clofarabine, low-dose cytarabine. And this is a recent publication which looks at a 5-year follow-up of this particular regimen. This is, again, without venetoclax. The complete remission, true CR rate 59% with complete count recovery, a CR/CR rate of 66%. This is in an era where there was no venetoclax. This is low-intensity therapy for older patients, median age 69 years, median survival 13.8 months with this combination. Now, we went back and said this is one of the questions we had is, do we really need intensive chemotherapy in this patient population? The Alpha group from France did a very nice analysis. This was published, I think, in Blood, which looked at a specific score. So they took a score looking at various gene mutations in patients 60 and older, only 60 and older, with certain mutational profile at the start of diagnosis. And they said, well, who are these patients who are best able to receive 7+3 chemotherapy? Who are patients where you may maybe select not to give them chemotherapy? And it was a nice group because what they had is all patients 60 and older who were treated with 7+3. We thought it was a great group to compare our old experience with cladribine, low-dose cytarabine. You can see here these are the two groups. Notice the median age identical, white cell very similar. In fact, our group had more patients with adverse ELN and 0 patients with favorable ELN in our group, where they had 3%. And they split into different categories, so-called the go-go group. These are very active, so these are patients who would benefit from 7-3, the slow-go, sort of intermediate, and the no-go, who you actually absolutely would not give the intensive chemotherapy to. And you can see here in this curve, what they also did is they took groups from the German AML study groups, AMLSG, and they compared all the outcomes. You can see in the first column is the complete remission composite rate with cladribine, low-dose cytarabine, again, without venetoclax. And you can see across there, the remission rates are very similar to what you saw with 7+3 in an older population, 60 and older, with intensive chemotherapy. So remission rates, not very different with cladribine, low-dose CRC compared to 7 and 3. And here are the outcomes by the different subgroups. On the upper left, you see the MD Anderson by the different groups, go-go, no-go, slow-go, and you can see the study alliance leukemia, AMLSG, and the other French group, where the outcomes are actually similar or even better in this sort of across-the-trial comparison of low-intensity therapy compared to 7 and 3 in this older patient population, if you started looking at the different subgroups genomically. So what I propose, and will be proposed for several years now, is cladribine, low-dose cytarabine as a new backbone to replace the HMA as a new low-intensity backbone for those patients who are older. We're starting to investigate now with cladribine, low-dose cytarabine, and gilteritinib in patients with newly diagnosed or relapsed AML. We saw that the AZA-gilteritinib trial did not actually show an overall survival benefit, perhaps the HMA-ven gilteritinib, but another option is to consider a new backbone. We're also looking at this with the IDH1 inhibitors as well as the combination with gemtuzumab ozogamicin. I'll show you a brief example of a study with uproleselan, which Claudia discussed yesterday, which is an E-selectin antagonist. And this can be considered for patients who are younger, older. So the 60 to 75 who are still sort of semi-fit, but you're not really enthusiastic about giving them intensive chemotherapy, who may not be suitable for anthracyclines, and they can still be eligible for allogeneic stem cell transplant. So briefly, I won't go into the mechanism of action of uproleselan. We heard about that yesterday. But what we found, this is working with the company, is that patients or cells that are treated persistently with hypomethylating agents actually upregulate E-selectin within the bone marrow microenvironment and engender chemoresistance. Does this sound familiar to anyone? These are patients, for example, with MDS who have been treated for months, for years, with hypomethylating agents, then they progress to acute myeloid leukemia, what we refer to as treated secondary AML. So newly diagnosed AML, but they've been treated for 6 months, 8 months, 18 months with hypomethylating agents, and now they progress to AML. And we call this newly diagnosed AML, which is a farce, right? Because they've been extensively previously treated. We give them chemotherapy. The response rates are 15 to 20%. Their overall survival is 5 months. So what we said is if HMA truly does increase E-selectin within the bone marrow microenvironment, these patients should have among the highest E-selectin levels in their bone marrow microenvironment. This would be an ideal population where we would use uproleselan combined with a regimen that does not include HMAs at the front, and this is an ongoing trial that we currently have in patients with newly diagnosed. So again, using the backbone and combining it with a novel agent here. And finally, I'll wrap up by looking at our trial. You've heard a little bit about this, where we combine venetoclax with cladribine, low-dose cytarabine as an alternating regimen. The cladribine is given 5 per meter squared for 5 days, low-dose cytarabine 20 twice daily for 10 days, and then venetoclax for 21 days during the first cycle, 7 or 14 days on the second cycle and beyond, based on your MRD negativity rate. And what we see here is just a top-line result: overall response rate, CR/CRi 93%, complete remission, true CR rate of 80%. And then someone asked earlier about the MRD negativity rate. 84% of patients were flow cytometry negative at the time of response. And then you can see here, when we looked at the different subgroups, whether you be newly diagnosed de novo, secondary AML, karyotype, ELN risk, the response rates were high across the board, with some minor differences in the rates of CR versus CRS. So a very active regimen in this older population with a median age of 68 years. The survival here, 2-year survival over 60%, and certainly those who are favorable had over a 90% long-term survival with a median follow-up of 18 months and counting. When we looked at patients over the age of 70 versus younger than 70, which is on the left, you saw no difference in the outcomes. And on the right, you see those who received a stem cell transplant, which 30% of these patients did, had an outstanding long-term survival of 90% at 2 years, again with an 18-month median follow-up. The final chapter is optimizing post-remission therapy. So these are the same patients, these older, unfit patients who require low-intensity therapy and ongoing maintenance therapy. We started with a trial of azacitidine and venetoclax maintenance, but at much lower doses. So with the success of CC486 in maintenance, we started with 50 milligrams per meter squared of AZA and just 7 to 14 days of venetoclax. And we see here relapse-free survival at 1 year not reached, 65%. This study is ongoing. And as Dr. Rawani mentioned, we now have an oral maintenance approach where we use 3 days of oral decitabine with various targeted agents in subsets of patients based on their mutation analysis with the outcome measure of relapse-free survival in this patient population who do not have stem cell transplant as a potential option for them. So, I think the next steps are we're going to use these newly targeted biological therapies within specific subgroups, develop new therapies within the new subgroups that we identify, investigate novel partners, not only with HMA-VEN backbone, but also think of new backbones that may be low intensity, and they may be able to leverage some of the new therapies that we have here. And they really need to work towards individualizing post-remission strategies, because remission rates are high, MRD negative rates may be high, but relapses still have not come down significantly. So I think that's what we need to work on next, and I thank you for your attention.